Very good. So good morning, everyone, and welcome to this webinar with Humour and GovConnect on the NHS recovery and how digital technology is helping to battle the growing waitlist backlog that we have today. We've got an esteemed members of a panel who have joined us this morning, and we are excited to be hearing with them and discussing this challenge, but also the opportunities that digital technologies can play. My name is Dr. Harpreet Sood. I'm a GP in London, but also sit on the board of Health Education England, and I'll be chairing this session today. And like I said, we've got a fantastic lineup. And before I introduce each of our panel members, I'll just like to remind everyone that the session is recorded and will be available for people to watch after the event. The event is split into three parts. We're going to set the context, the reference cases, and then we're going to have the discussion. And we'll be taking questions throughout the webinar, so do post your questions in the chat function, and we will get to them during the Q&A session a bit later. So let me briefly introduce the panels and then kick off. We're joined today by Sir Jim Mackay, who is the Elected Recovery Advisor for NHS England and Improvement, and also Chief Executive of Northumbria Healthcare NHS Foundation Trust. We've got Lisa Hollins, Director of Innovation Delivery at NHSX. We have Vicky Jenkins, who's the Chair of the Betsy Quitting International Health Partnership and also Heart Failure Advanced Nurse Practitioner for the Betsy Cadwaladr University Hospital Board in Wales. And we're going to be joined through a video by Mr. Sunil Budia, who's a co-lead of cardiac surgery at the Royal Brompton and Harefield Hospital. So, like I said, a fantastic lineup with lots of different perspectives. And so without further ado, let's get into it. So in terms of setting the context and understanding the scale of the challenge, I'm going to turn to Sir Jim Mackay first. Now, Jim, you've seen that, given the mammoth task of guiding the NHS through its recovery, and that's a big part of your role now. It'd be great to hear from you and get a summary on the scale of the challenge, how we might tackle it, and what would be needed to scale the innovation that we've seen during the pandemic to tackle some of this.
Okay, great. Thanks for that. So I'll just talk for a few minutes and just give a flavour for the sort of things that are on our minds, everybody's minds, as we try and work out how we're going to get through the next few years. So the first point I would make is it's very easy to say all of our problems started last year because of COVID, but we actually were in decline prior to that in terms of the key metrics, and we already had an imbalance of supply and demand and very, very well discussed problems with the workforce and fragility in parts of our system, etc. So we've actually got to do more than just correct what happened last year. Much of the focus is obviously on the size of the elective waiting list, and usually in these conversations we end up focusing on complex operative surgery, but most of the waiting experience doesn't ever go anywhere near a theatre or an operating list. It's the vast majority of our waiting list, over 80%, is non-operative, and I think there's a big opportunity in that as well. And I think there's opportunity in learning from last year, technology innovations, innovation generally, the agility of the NHS in extremis to be able to scale up and change in an incredibly agile and rapid way, and try and use some of those things in terms of how we respond over this next period. When we have this kind of problem, it's very hard to work out where to start. And I think when we're looking at this, you can feel a bit of panic actually when people are looking at it and think, well, where do I start? I think in these times, you've got to go back to the data, first of all. So let's understand what it is we're actually dealing with. What do we mean by the backlog? What do we mean by success? So what recovery means is different things to different people and different places, etc. So if I summarise what I think success is probably a political thing about getting at the next election back to December 19 levels in terms of size of the list and waiting experience. There's something about the NHS and staff feeling like we're on top of demand and be able to cope. The public will feel like the NHS is actually open for business, they can access their services in the way they want to. and the Treasury have bought more activity. Some of those things work against each other, so there's a bit of tension in some of those things that we just need to be careful about. But also in that, there's huge opportunity. And there'll be a combination of, we will have to do more work and we'll create more capacity and we'll see more patients and treat more patients, etc. But I think there's huge risk on entirely backing the horse that the NHS will just do more work and our staff will work harder. I think there's an opportunity here to change the game. We have to find some game changers. And this has obviously got a technology bias. So the way technology enables that, I think that's really key. We have to be really careful as well, though, and I'm slightly worried about this at the minute, to avoid the chase and shiny object thing where people want technology for technology's sake. It's got to be useful for patients and staff and produce a benefit and an outcome. So from my point of view, there'll need to be some edge in the business case to make sure that we can actually measure that and it delivers that. And I think especially stuff that helps handle the patient's waiting experience and fundamentally gives the patient more choice and control of their utilization of the service, what they get, when they get it, how they communicate, how they get advice, and giving them more choice and control. And I think if we could do that, there is huge opportunity for how we change the game and reshape what we do and avoid just saying to our staff, work harder. So that's it from my perspective. Happy to open it up and have a discussion.
Brilliant. Thanks, Jim. That's a really cool context setting, and obviously the scale of the challenges is vast, like you said. Just a couple of points I wanted to pick up on then. Firstly, you talked about the importance of the benefits to patients and obviously improving outcomes. I mean, through the work you're doing and kind of solutions out there, what kind of things are you seeing that are actually helping us to improve those benefits or outcomes? Have you seen some good pieces of work that have come through?
Yes, so I haven't seen it directly myself yet, but I've seen a summary of it as an example, is the Milton Keynes software and approach to giving patients the ability to access their own care, so to organise their own outpatients and interact with the hospital and the clinical team. I think looks very, very powerful. There's some good stuff around about using AI to cleanse lists and generate more intelligence, which looks fantastic. I met with a surgeon yesterday who's a robotics enthusiast, but also with a fantastic AI component, some very compelling data about improved outcomes by improving predictability of risk, etc. So we've got dozens and hundreds of these things around the NHS, but our enemy, as always, is we often don't know about them. There'll be something fantastic going on next door, and either you don't know about it or actually you're allergic to it because it's next door. And we have to find ways of getting over ourselves on that. But as I said earlier on, I'm also aware of an awful lot of opportunism, repackaging things to say this is worth investing in on the back of recovery when it's actually just not. Selling things that really aren't going to make an impact, but we're dressing them up in a way that they are. So I think we need to be quite ruthless about the tests of, does this help the patient and does it help the staff? And if it doesn't, why we're doing it.
Yeah, absolutely. And I think that's key. And just a quick follow-up on that one, I mean, and this will also be relevant to many of the audience members that joined today, in terms of then, how we share that learning and help scale. I mean, would you have some thoughts on that in terms of how can we do that? Because ultimately what we always find is that you have to lose trust and have to do everything again and again. Whereas actually with the time limitation we have at the moment and the need, how do we scale and adopt quickly?
Yeah, so I think this is one of our biggest risks, because the NHS is huge. It's an enormous thing, isn't it? It's like a small country in reality when you look at how many people are involved in the geography, etc., etc. So I think the honest answer is we're actually working through this now on a number of interventions to see which of these things are actually we do once, we only do it nationally, there's no choice. Which things we can set a policy and we can say, you work it out, that's fine, as long as you do these things, that's fine. And there's probably, on a scale of maybe 6 or 7 different kinds of approaches and interventions that suit different circumstances. So I think, sadly, it's a complicated toolbox approach where we have to say, actually, this is a hammer, this one's a drill, this one's a screwdriver, depending on the kind of thing that we're actually trying to solve. And also in this, we haven't got a lot of time. So we have to balance the risk of we've actually got to get on and do some of these things quickly, which takes you towards a more directive approach, but understand that the risk of bad adoption and bad execution is massively increased if you do it in that way as well.
Yeah,
so
brilliant.
There isn't an easy way out of it.
Absolutely great. And then the second question I had, which was, again, picking up some of your themes, being a clinician myself, I want to engage in technologies like this, and Boom is one example, and we've done some or doing some good work on that. But everyone talks about the headspace and how we need to engage clinicians when it comes to kind of credibility and the evidence side of things, because you have the business as usual where you have to run the service, but then you want to be introducing some of these new technologies. Again, through the work you're doing, and you mentioned this example of the surgeon that's doing work in the robotics space. Are you seeing more and more examples of that where clinicians are getting more and more involved in terms of helping to drive this forward? And what would be some of your thoughts behind that?
So honestly, I don't think we're short of ideas, either from the clinical community, the management community, patients, the tech world. I think we've got more ideas than we can digest. I think it's actually getting those ideas to decision makers and working out who the right people are, who can actually say yes, take a risk, agree which things need backing, etc. I think that's actually more of an issue for us now. There's massive enthusiasm, and there's loads of enthusiasm as well to say, let's change the game on all this. Let's not just build what we had before COVID. There's an opportunity here, but the risk when the pressure's on is that's what we do. We just build it exactly the same.
Yeah, brilliant. Well, thank you, Jim. It's been fantastic to get your thoughts and some of your insights. If I can then move on to Lisa. So Lisa, again, thank you for joining. Now, Director of Innovation Delivery at NHS. Your task is in some ways no smaller, but we know that there's been a huge amount of innovation during the pandemic, and so Jim's kind of highlighted that. But what we have really seen is, with some of the technologies that we're seeing, it is making a difference. But the question is, does it have good evidence? And I think that's always the kind of pushback and challenge people bring up when we're discussing this. So what would be great to hear from you is, what strides NHS is making in sporting innovation and enabling the adoption at scale that Sir Jim has also outlined. Oh, Lisa, I think you're on mute.
Thank you. Somebody had to be the person who did that. So thank you very much, Harpreet, and really good to be here. So I thought I would talk through just a little bit about what NHS is doing, some of the major things that I've seen coming through, which are, I think, of note, and probably do fit into the category of 3 or 4 things that we can do nationally, and just say a little bit about some of the evidence and evidence that's out there that's available to everyone. So I think firstly, NHS has been around for 2 years now and was brought together to accelerate the adoption of innovation. But what we know is that there are a fair few things that we need to fix. One is the investment in technology architecture and kit nationally, and we can see that in the Provider Digitisation Fund, which has just been approved by Treasury, and the announcement will be out in the next week or so, that we need the right kit to undertake the work we're doing across the NHS. The second area is that we have so much data. We have about a quarter of the data in the world is health data, so we have huge opportunities to do some of the risk-based and prevention work. We need to do that well, and we started to see some of the changes in shared care records. So the hospital that I used to be the CIO of, I think one of the most fundamental things we did was to make sure that the hospital care and GP practices could see each other's records, and they could make sure that when prescribing, they knew exactly what had been prescribed in the hospital, and they knew what tests, and that information was up to date, and that made a huge difference. But there's much more to do. And we'll see more of that work as the funded areas within the National AI Fund start to bear fruit over the next 12 to 24 months. And then the final area is how can we transform and really change our services, because we know we are suffering from all of the difficulties in capacity and demand that the rest of the world are, in terms of a demographic that needs a lot of time and attention, the excellence in medical research, which is stretching the possibilities of what we can do, and a constrained workforce. And of course, there's always some constraints on funding that any the country needs to contend with. So we have quite a lot of constraints, increasing demand, and we need to find some ways of how we can do that. And I think that's where technology can really operate and offers a silver lining to some of the huge areas that we need to do. So just to say a few more areas about the things that I've seen that I think are very transformative. I think the first area I wanted to say was how we look after long-term conditions. What we've seen in a whole range of organisations across the country is that we are people are onboarded onto virtual wards or remote monitoring, where they can be put much more in charge of monitoring their own care. It doesn't suit everybody, but it can suit a whole range number of people, and it has shown significant benefits in cardiac care, in respiratory care. It did show a range of benefits over the pandemic, and there is an evaluation out which showed actually it reduced by half the amount of clinical time as people were monitoring themselves at home. And of course, this means we don't wait to visit a healthcare site. If you can monitor at home, actually you can get much more plentiful recordings, and that's is of course available. So that's the area that I would recommend. It had a huge impact on COVID pathways, but it's starting to have a huge impact on cardiac, respiratory, rheumatology, gastroenterology, and there's lots of examples out there. And I think we're going to talk in more detail about the cardiology one later. And then the third area is around elective care. So for people on the waiting list, there's lots of rehabilitation and self-management tools which do have an evidence base. They're reviewed and evaluated by clinical teams, and often the technologies are led by clinicians, and they're starting to have a huge impact on people waiting. So one of the national tools, Escape Pain, is in most ICSs across the country. And there's a evidence base around that tool. So huge amounts of tools that are coming out that can make a substantial difference. A lot of these tools reduce the outpatient appointments by 50%. So there's a lot of evidence, but throughout all of them, what we're aiming for is to increase access to patients, to make sure they can have a choice, and they should always have that choice, whether they want to come to a site or have care at home, to reduce the amount of time it takes for clinicians, because we know we want them focused on the patients that really need their care, and to try and automate some of those very transactional admin tasks for them. And I think those are the really key benefits: releasing time for clinicians, improving access and experience for patients. And those are the metrics that I would use to measure any of the new technology transformations. And then finally, I just wanted to say, and I'll put this in the chat, the first thing that people said to me when I left my previous job in a hospital was, please just review the innovations that are out there, because people don't have time if they're incredibly busy within their jobs in organisations to review all of the different technologies. So we've done that for them. So for all of the major long-term conditions and high volume conditions, we've produced digital playbooks. There's about 130 different case studies there of technologies that have worked and technologies that are recommended by hospitals. So within 3 clicks, you can find out if you want to look on a respiratory pathway to support people monitoring at home, you can have a look at those technologies. So I think that's really important because it saves people time, but also all of those case studies are ones that are recommended by clinical teams that have inputted those technologies within their own organisation and can recommend them. So those are the areas that I would want to mention.
Brilliant, thank you, Lisa. That's a tour de force of all the great stuff that NHSX is doing. So thank you for that. Again, a couple of points, if I may, just wanted to ask on. One is that I think you guys have also done a very good job with bringing together all the funding sources and kind of with the Unified Tech Fund. So now more funding for hospital at home, remote monitoring, and the buckets of money there. And what would be your kind of thing around how we then engage with the rest of the system to use that money in a much more effective way, and then linking to what Sir Jim said around, helping to adopt and scale some of this? I mean, would you have some thoughts or advice on that for people watching?
Yeah. Yes, thank you. And Harpreet, what you'll know is that the Unified Tech Fund elective care funds are out at the moment, and people are bidding for the different areas for elective care in terms of technology. I'll put the link to the Unified Tech Fund just in the chat so people can have a look, and that's for healthcare organisations just to review potential funds that are coming up or funds that are there available. And to, of course, gives all of the guidance. It's in one easy place, because what we know is when we make funding opportunities available, it's sometimes difficult to make sure they get to where they need to. A lot of the innovations come from clinical teams and from the front line, and we need to a way of connecting those areas. So I would recommend that to have a look at that for people. And then in terms of good practice, in terms of implementation, the metrics are really important. Having people within your organisation that can do the project management for you, and a lot of the funds wrap the funding for those project managers up within the bids. And to work with a group of people who are perhaps doing the same type of changes that you are. There are all sorts of collaboratives and communities of interest that support people to make those changes. So we know it's and I found that in my previous organisation, it's quite tricky to make sure you've got all of your ducks in a row, really, from the technology team who have some time and space, from the operational teams who need to realign their processes if they're adopting a technology, and our clinical teams to support them to have the right clinical protocols. If you're implementing a new digital clinical pathway, all of those things need to come together with information governance guidance. So there's quite a lot of advice in some of the national innovation collaboratives of people who have done done exactly those things: the case studies, the business case templates, the data privacy impact assessments, all of those documents that you need to do. So we've tried to gather that together to help people to do exactly that.
Brilliant. So I think we need to give the list that you guys have created to Sir Jim, and then try and bring those two together, and hopefully we can adopt and scale these solutions, which would be great. Excellent. Well, look, thank you both for setting the context. We now get the challenge. I think our viewers will understand the complexities, but also the scale of the problem. But I think it's good now if we move into the second part of this webinar, which will be to look at and bring up some of the case studies where we have been supporting patients through a digital pathway. And also, Sir Jim, it would be great to get some of your thoughts on that as we hear about these case studies in a bit more detail. So let me move to Vicky. Vicky, you're a heart failure specialist nurse, and obviously you've been working on the Bessie Cavaglia University Health Board in Wales, and you also care for community patients with chronic health problems. I think it would be fantastic to hear more about this project, how it's going, and the impact it's having. Thank you, Vicky.
Thank you very much, and thanks for having me on the panel as well. So yeah, I'm Vicky Jenkins. I'm a heart failure advanced nurse practitioner, and also accredited in echocardiography, scanning hearts, up in rural northwest Wales. And I've been wanting to develop a remote monitoring system for quite a few years before COVID hit. And I think COVID has helped to sort of expedite the need and desire to get these developed. Next slide, please. So what do I do? What's my service? So primarily, we look at focusing on upstream management. We want to identify people before they become unwell, before they present at hospital, in diagnosing them with heart failure so we can get them onto the right treatments. We also, when we've got patients that are diagnosed, we try to help them avoid a hospital admission by timely and appropriate evidence-based management. And we also try to facilitate an early discharge, even more pressing in these COVID times. I see any adult with a diagnosis of heart failure with reduced ejection fraction. And it's really important to empower the patient and give them a tool kit to spot when their symptoms are deteriorating, so that they know how and when to contact me, titrate their medications and manage decompensation. So if they're filling up with fluid, I help to offload that, hopefully in the community. Next slide, please. In the community to avoid hospital admissions. So my journey to going live with this remote monitoring digital heart failure app. First of all, it's really important, I feel, to say I'm a nurse, not a researcher. So I'm really novice in this research journey. It's been a massive learning curve, and I couldn't have done it without surrounding myself with people who can guide me, link me into people who can help. So I initially, as I said at the beginning, wanted to, about 3 years ago, develop this remote monitoring app. My dream, that the creme de la creme for me would be an app that patients could use remotely, independently of day-to-day interaction with their specialist, to titrate up their medications, and they would put in their readings, their blood pressures, their pulse, their oxygen saturations, and the app would say, for you, you need to change this medication to this. Now, refer you back to my first point that I'm a nurse, not a researcher. What I found out is that's massive. That's maybe 10 or more years down the road. That needs the same kind of medical clearance as an inserted pacemaker. Yeah, that's classified as a device. So all of these networking, meetings, conversations, finding my support networks, we sort of had a bit more of a realistic picture of what we wanted to develop. And then there were funding challenges. The NHS hasn't got pots of money necessarily lying around for a clinician to go off and do a bit of research and at the same time managing the caseload. And just as I was starting to wonder if it was ever going to happen, that's when I found Humour and my colleague, Mandy Welsh, who's almost the same sort of role as me, but in Cumtaf Health Board, who were just about to sort of launch a very similar sort of pilot. So we joined forces, and I jumped in with them, and we decided the parameters, exactly what we wanted to monitor and flag as red or green alerts. Then we had to go to our health boards and get governance sign-off. So that was another huge learning curve. That was really challenging for obvious reasons. You know, you've got to protect patient data and make sure it's watertight. I didn't want somebody kind of tapping me on the shoulder in a few years and saying there'd been some sort of data leak. And that did cause a bit of a delay, but we're live. We're coming towards the end of our pilot. Next slide, please. And it's been a really exciting experience. So I'm not a tech geek, and I was a little bit worried that this process would, I'd get to go live and it would be really clunky and difficult to use, that I would struggle with the digital technology myself as a clinician. This is an example of the dashboard that as a clinician you see, and you click on each one of those boxes and it takes you into a more detailed version of their blood pressure that day, their weight. With heart failure patients, weight's really important. Oxygen saturations, symptoms such as breathlessness or thopnea. Next slide, please. So it's really user-friendly, really intuitive and easy to use. And I've been really delighted with how easy it's been for myself to use. We've just had the midterm report released, and the interim results are really positive. We've been able to, myself and Mandy have been able to undertake a variety of approaches, facilitating early discharge, monitoring people from home and preventing hospital admissions by checking matrices such as heart rate, oxygen levels, quickly escalating weights. And we've been able to, because of what we've seen on the dashboard, instigate extra tests, support, or earlier treatment. It's anticipated that the findings will show that this cohort of patients, its remote monitoring is not just reliable, but it's really useful and can help to keep patients as well as possible for as long as possible and out of hospital. So interventions, a few examples of interventions as a direct result of what we've seen on the dashboard. We are managing, Mandy and I are managing either Worried Well. So as a result of some publication on BBC and in the papers, which I think there's a link for on the presentation, I had a patient contact me who, because of COVID, he'd fallen through the monitoring cracks, and he wanted to know that a cardiology nurse in the meantime, so they could see their cardiologist, was keeping an eye on them to be reassured. So that reduced unnecessarily Worried Well contacts with the NHS. We were able to facilitate somebody coming out of hospital sooner because we could manage them and monitor them more accurately. And also I spotted patients who were deteriorating and managed to change medication to be able to prevent them going in with hospital filling up with fluid. Next slide, please. So the picture in the middle of this screen is an example of what our patients will see on their phone when they're inputting their information. They'll click on each of those boxes and put today's weight or reading symptoms in. Some of the feedback we've had from our patients have included what you can see on here. They find it really quick and easy to use, and the clinicians find it helpful to see a trajectory of their patients, what the pattern is. The patients, it's reassuring to know that my heart nurse is watching me closely. Again, very easy to use from a patient point of view. And I think my favourite one is this is the best app on my phone. Next slide. I can't remember if there's another one. I think in summary, it's been a really exciting experience. I've been delighted with how easy it is. And I really hope that we can sort of see this develop and we can evidence that this is really safe and useful to use to keep our heart failure patients out of hospital. Thank you.
Brilliant. Thank you so much, Vicky. And, really great to hear that humour in particular with this particular example helped you achieve your dreams that you set out with. So excited to hear about that. Look, I think a couple of questions for me, and it's really good to hear about the patient stories, but also how this is improving the outcomes. I mean, obviously there were very positive patient outcomes from what you've just described. My first point, were you surprised by them? And also on the back of that, if this was to become a new way of working, what do you see as a potential benefits to both patients and the clinical care teams?
I mean, there's, I could talk for ages on some of the benefits and advantages. I think the primary thing for me with my patient cohort has been spotting sooner. So my patients have my work mobile number. They contact me if they feel they're deteriorating. But quite often patients are really worried about bothering you. They know how busy their clinicians are. And sometimes by the time you get that message from them, it's too late and you've got no choice other than to send them in. So this way I can jump onto my dashboard on a daily basis. I can see patients who are engaging in their self-management or not. I can see patients who are deteriorating. I can also see if what I've done is having the effect I want, or if they're continuing to deteriorate. So I think that it's just really exciting to be able to see almost live what your patients are doing. And my colleague Mandy has also spotted somebody who was getting very bradycardic. She ordered an ECG, and medication changes were made because of that. So there's other things that you're picking up as well that are keeping patients well.
Got it. So it does seem like you were surprised by it, but at the same time, it also seems like you've gone out and developed a solution and are providing that solution for your patient, which is important. I guess the second point being that, could you see projects like this supporting patients across the NHS in a wider range of cardiology pathways and therapeutic areas from your experience?
Yeah, definitely. And I know Humour have already got a few other examples of this remote monitoring with patients waiting for surgery, etc. But yeah, diabetes, respiratory, yeah, there's quite close links between heart failure and respiratory. It'd be really nice to maybe see a platform that merges those. So I think it's just something that's going to grow. We've got to make sure we do it safely and evidence that, and get support from places where we can, as clinicians, where do I go for funding? Where do I go to make sure I'm safe doing this? How can I maintain my caseload whilst trying to be innovative? But yeah, definitely, I think that there's going to be more and more room for this sort of technology.
Got it, thank you. And so, Jim, I just wanted to bring you in on this. I mean, what would be some of your thoughts on what Vicky said around expanding this to different therapeutic areas? Oh, sorry, I think you're on mute.
Can you hear now? Is that okay? So I think it's exactly the sort of practical innovation that we're looking for. It's clearly beneficial to patients. It helps clinical colleagues as well. So, and it looks very transferable in terms of its adaptability to other kinds of patients, etc. I'd just be interested to get your view really on what would make it easier. How, I've got a sense of it wasn't absolutely easy to get it all organized and approved and stuff, but what would make it easier to get these things off the ground?
I think that, having signposting, really clear signposting, having a bit more awareness raising for clinicians of where they can go, that this is possible. Engaging in forums like this is really important, I think. And it's really important for me to say right at the outset, I'm not a researcher, and getting those networks around you. And then also for NHS trusts and health boards to be supported with signing off information governance so that clinicians can move forwards. That was, as I say, quite rightly, quite understandably, quite arduous, difficult, challenging, and we had to keep going back, and we thought we got signed off and we had to go back again. So that support for the organisations with the governance side of things, and some more guidelines about it's okay for this to be approved, so that clinicians can push forwards. Oh, you're on mute.
I think we might have lost Harpreet. I just wonder whether we should just say a few more comments. Perhaps there was just a couple of things, Mark, you were talking that I was thinking. It sounds fantastic, Vicky, that what you've done, and it is quite a leap of courage, really, isn't it, to adopt something completely new with new protocols. The principles of monitoring cardiac patients I think are very similar to monitoring lots of long-term conditions, and if you are able to get the vital signs from patients at home, actually we've seen quite a lot of improvements in a whole range of different specialties, but it's great to hear about it.
Thank you. You're on mute.
Oh, there we go. Thank you both for that, and thank you for again sharing that case study and those examples. I just now wanted to bring in Sunil, who I spoke to last week, who we recorded. So and I wanted to get his views across on his experience at the Brompton. So if you can share the video, please. Thank you. Okay, so now we've got Mr. Sunil Budia, who is co-lead of the cardiac surgery at the Royal Brompton and Hayfield Hospital. Sunil, you're a cardiac lead and your team brought in humour to help during the pandemic. It'd be great to get insights from you on what were some of the challenges you were trying to meet and how did the system work for you and the team, and is it making a difference?
Sure. Thank you, Harpreet, for the introduction. As you mentioned, I'm the co-lead for cardiac surgery at Hayfield Hospital, and we work very well with the humour, and I'll tell you how it all started and how we have collaborated since we started working together. So we at the beginning of the pandemic, which was around March of last year, we came to realize very quickly that the world is going to change, and more importantly, the world for patients was going to change, and how we work as well. So across London, Hayfield was tasked to look after cardiac surgery patients across London together with BARTs. So out of the 7 units, two units were tasked to undertake operations. So you can see straight away from a huge number of centers doing the surgery, only 2 centers were doing surgery. And then doing the operations and the logistics of the operations, getting surgeons here was not an issue because we've done that in the past and we are happy to do that. But what started becoming very clear to us was how are we going to monitor our patients? Because there'll be loads of patients sitting at home waiting for their surgery, and we didn't have the capacity. So we had to reclassify each and every patient as to their urgency for the operation, and ensure that those who are more urgent had their surgery first, and for obvious reasons. But again, we also wanted to find out those patients sitting at home, are there any of those patients deteriorating? So one option was for us to call them up and ask them how they're doing, whether their symptoms are getting worse. But it became quite apparent that by the time we reached the last patient, we will be calling the first patient up again to see whether that patient has deteriorated or not. So the obvious answer for us was to look at other technology, and humour is where humour came in, because humour had the technology to monitor patients on a virtual format. So we gave patients a login and certain symptoms that they could tick, and to see whether they were flagging up on any of those symptoms. But more importantly, were they deteriorating? So most of our patients get chest pain, but we wanted to know, was that chest pain getting worse? They get shortness of breath. We wanted to know whether they're getting worse or not, because if they did that, then we had to reclassify their urgency. So just giving you some numbers. So over a 6-month period, we with humour, we had monitored 525 patients. And of those 525 patients, 10% of the patients showed deterioration. So clearly that's a big number. So that's over almost 60 patients. And of those 10%, almost 90% of the patients, we had to bring their surgery date forward, and so that we could operate on those patients in a timely manner. And this served, the platform served multiple purposes for us. One, it was for us to get reassurance that we're monitoring our patients, but also for the patients as well, because patients were afraid to go out. It was a new world for everyone. They didn't know what was happening out there, but also for them to get reassurance that someone was keeping an eye on them, just in case if they were to deteriorate, then they could flag that up and someone would call them up to follow them up and get their surgery expedited. We also realized that it's not only the pre-op that we are interested in, we also wanted to see what we could do post-operatively, because we could not get patients into the hospital for for their outpatient clinics for us to review them. So we used the Huma platform to monitor our patients in the post-operative period as well, which was good success. And if patients had any concerns, then they could flag that up on their platform, and we would get in touch with them sooner than we would have otherwise contacted them. So normally we contact them at 6 weeks. We would contact them sooner, and some of the things that we did after this monitoring was we would modify their medication or look at their wounds, get them in to look at their wounds, or virtually we would look at their wounds. So these are the various tools that we used to get in collaboration with Huma for improving the care for our patients.
Brilliant. Very good, Sunil. So obviously quite a lot happened there, and quite a number of different use cases that you demonstrated. So it seems like it's been quite a interesting experience for you. I just wanted to ask a couple of questions on the back of this, if I may then. So firstly, I mean, have the results surprised you? And linking to that, do you feel that the experience that Royal Brompton has had, do you think a similar approach could benefit other cardiac centres and networks across the country?
Sure. The results, obviously, we don't have any other results to compare with, but these were quite encouraging in the sense that not for the patient that they're deteriorating, but encouraging that we can identify these patients without them having to come to us. So in the past, we would have relied on us making a phone call to the patient, or patient going to the GP, and then the GP getting to us. So we are sort of shortening the length of time it takes for a patient to get in touch with us to tell us that something is not right with them. So 10% is a big number, and if we can escalate the operation and get them done sooner, then we've saved quite a lot of lives like that. As you appreciate, cardiac surgery can be life critical, and if we get it done in a timely manner, then that would save lives. The other thing is also for the symptoms point of view. If the symptoms are getting worse, they're not able to do things that they are able to do. If we can bring their operation surgery date forward, then of course that would benefit them. But if you look at the scale of the problem, we can't call every patient up. It's just time consuming. This is a more efficient way of doing it. We have suggested this to the Pan London group, because we have a Pan London cardiac surgery group, and they have taken this as an exemplar sort of way of monitoring patients. So other hospitals are considering this, and we have been encouraging them as well, because this is the way forward. And as I've said, we also want to look at other avenues of monitoring patients post-operatively as well. Yeah,
no, very important, and it's good to, well, encouraging to hear that that's obviously being looked into now, and other centres and hospitals are looking at this as well as, like you said, the positive results that you've seen. Well, and then the second question I had on this is that, do you kind of see, or could you see similar digital tools that benefit other pathways? So obviously we've got cardiac, but other surgical specialities or other kind of pathways that can help support the NHS recovery.
Yes, I mean, cardiac surgery, if you look at the number of patients waiting for cardiac surgery, is probably small compared to, say, for someone waiting for orthopedic surgery, hip replacement or knee replacement, someone having eye surgery. Those are big number of patients. So if we can monitor these patients in a more, as we've shown that this is a more efficient way of monitoring patients, and it's less labor intensive, and we know that it works and it flags up patients who are deteriorating. So if we extrapolate that to not only cardiac surgery in the rest of the country, but if we extrapolate that to other types of patients, like we mentioned, orthopedics, eye surgery, then we will free up staff who are trying to monitor these patients to do other important things in the NHS. As you know, NHS is struggling with the staff recruitment and also the number of staff working. So this will help free up staff to spend more time on where they're required. So it has a big impact. It has potential big impact in other specialties as well.
Brilliant. Thank you so much, Sunil, for your insights and your time. And it's really great to hear some of the results in this, and we look forward to hearing more further developments as they come along. Thank you, Sunil.
Sure. It's been a pleasure, and keep at it. And I think we'll do the right thing for the patients.
Thank you. Brilliant. So that was a great conversation I had with Sunil last week. And again, a testament to the work they've done at Royal Brompton, but also shows the link that Vicky made and what we're hoping. I just wanted to open up now for questions. We've had a few questions come in, but before I do that, I just wanted to get a sense from both Lisa and Sir Jim on some of their reflections on what we've heard from some of the case studies and how you think we can start considering about the whole scaling up, because I guess there's, through our audience and through people we've spoken to, is that, like we said, we've lots of good ideas, but how do we now start bringing drastic measures in some ways to start scaling up some of these, because we know there's evidence there, we know some of the good things that are happening, but the challenge remains about adoption and scale up. Any thoughts on that? Lisa, if I go to you first.
Sure. Thank you, Harpreet. So I did post a couple of things in the chat which might be helpful to people. So we've got together with a number of the Royal Colleges and associations to give advice and guidance on these areas. So we published guidance. There are seminars that we've held over the last year, which people can download. They're all on the Royal Colleges and Associations website. So people who've been particularly active, the British Association of Dermatologists, the Royal College of Physicians, Association of Gastroenterologists, the Association of Physiotherapists. So they've all been really active on recommending digital tools. So it'd be good for people to have a look at those websites and the joint seminars that we've been doing with colleagues. So I think those are very useful. I did point to some guidance that we did specifically on elective care on those specific areas, and the tools that we'd seen that were particularly helpful with pre-op assessment, post-operative rehabilitation, and supporting people who were waiting on waiting lists. So, and that's again on the elective care part of the Unified Tech Fund website. So that there is quite a bit out there. But if there are, we're happy to have feedback and suggestions of if people think there are other areas that we need to do. Happy to help and support those.
Brilliant. Thank you, Lisa. And so, Jim, did you have anything on the scale up side of things from the solutions that we have?
Yes, so both have been really impressive, haven't they, and just very practical and useful. I think the thing that's going through my mind is it's very, very hard to see the wood for the trees. I get maybe 30 things in my inbox or brought to my attention every day that look like innovations, technology innovations, etc. And probably 29 out of the 30 every day are just not worth reading. And it's very hard to filter that, and you get very fatigued with it. So I think some method of sharing things and demonstrating that they're useful and helping people engage with each other, because we all trust colleagues more than we'll trust the industry bringing these things to us, etc. I think that feels like it would be useful to do. I don't know where the responsibility for that sits, whether that's NHS I&E or NHSX or wherever, but I think someone needs to get into that space to just help people work out which bits are worth looking at, which bits aren't, and which are actually endorsed by the people that use them properly. Yeah, absolutely. I think that makes a lot of sense. And linking with some of the clinical champions that can also drive this forward also, plays a really, really important role. There's been a few more questions that have come in, and if I can just open up to Vicky as well. There was one in particular around engaging with patients and how you keep them engaged, but also those patients that may resist technology and cannot use mobile phones. I mean, have you thought about some of the solutions to that, to both those questions?
Yeah, absolutely. And that's a problem, a thing that you need to be aware of a side of digital technology is keeping patients engaged in looking after themselves with their chronic conditions. So that concept isn't really new. And I think that it's really important that you have a toolkit, you have a variety of different approaches so that you can adapt to your different patients' needs. Exactly the same as when I'm sitting in patient with a clinic, I'm explaining to them their diagnosis, what that means. I pitch it slightly different. So it's the same information I give or the same service that a patient receives with or without digital technology. You just adapt it, you flex to meet your individual patient's needs, because different people come with different understandings. I live in a very bilingual community. I have quite an aging population generally, although I've got some young patients as well on my books, young adults. So you just judge it and assess your patients and pitch it, and you have to use different approaches. So because somebody can or can't engage in digital technology, that doesn't mean that their care is compromised at all. You've got another option, another approach that you can use.
Got it. Thank you. Okay. Conscious of time, and I've got last few minutes here, so I'm just going to ask two more questions to the panel. First is, do colleagues feel on the panel that there is scope for remote monitoring to support UEC services over the kind of the winter period? And if so, where? If I come to Lisa first.
Yes, there are projects that are going on, and those projects are looking at how to best to triage patients and put patients into an appointment where they possibly can. And there's also projects around just monitoring waiting times in areas. So there is quite a bit happening, and I'm happy afterwards to find the link if that's helpful for people. I can forward that on to people.
Brilliant. Thank you, Lisa. We'll take that on board. And then the second question being, what specialities or pathways do you think are in immediate need for digital innovations? And if I come to Sir Jim, both as your hat on as an elective advisor to the government, NHS, but also as a CEO of Northumbria, what are you seeing with some of these potential solutions?
So I wouldn't restrict it to any specialty. I think remote monitoring is applicable to any long-term condition, and I think we have to try and think of those patients in the round as well, because they've usually got multiple long-term conditions. So I think something that's built to be patient-centric and not disease siloed, I think is very important. If I may, I would go back to the earlier question and just thinking of applications. We had a discussion around urgent care a few weeks ago, because we're all under a lot of pressure, about the patients who are awaiting a test result and that can hang around in ED waiting for ages, especially when you're very crowded. And we usually have physical places to put those patients. I just wonder whether there's an opportunity to build a virtual place where we do what we need to do, get the test, and then they can go and be monitored and be able to communicate back with the hospital. In the hospital, 9 times out of 10, the test's absolutely fine. But just given that safety net to encourage people to say, you can actually go, you're out the department, we've declogged, etc. You've had what you need. But then if there is a surprise in the result, you're keeping an eye on them and you can call them back. And I think that's got potentially big value for ED departments.
Okay, so we're at, sorry, did you want to come? No, you weren't putting your hand up. No. Okay.
I could just comment. I think that's a really good idea. There's no reason why we can't onboard people onto remote monitoring platforms and just follow up with them. And if they did need to do any vital signs monitoring at home, we could absolutely do that on the same platform in the same way that Vicky does that in her practice. And what we're seeing now is that organisations and ICSs and even region at a regional level, people are picking the same platform. So if you've got 2 or 3 long-term conditions, you're on the same platform. Or if you need to go to 2 or 3 hospitals because your condition is perhaps that you've got a specialist condition and need to move organisations, you're on the same remote monitoring platform. So the options are quite significant in that area.
Brilliant, thank you, Lisa. And I think one thing that came from John Murray was, can we use innovation-friendly public procurement procedures to avoid scaling disconnect? But maybe we should take that offline and see what we can potentially do with that. Brilliant. Well, look, I would like to just extend my thank you to all of you for joining this morning. It's been a real tour de force in terms of, hearing about the context, the challenges, and the opportunities we face across the health system in the NHS, but then also hearing about some of the excellent case studies and examples of real-world implementation, how this is improving patient outcomes, but also benefiting clinicians and allowing us to engage with patients in a very different way. It seems like we're just at the foothills, and there's a tremendous opportunity in this space, and a testament to NHSX and the NHS for providing funding, but also the advice, guidance, and pathways on how we can think about the transformation agenda. So we are hugely excited, and we look forward to taking this further and engaging with all of you. Thank you all for joining, and I wish you a very good morning and have a good day. Bye-bye.